time in there.
Oh, we're recording. Okay, great.
Now we are, yeah. So
pay attention.
Pay attention. Okay, let's see. Okay, Monica, would you just mind unsharing your screen, please? There we go. Okay, so people are coming in. I think we'll give them another minute or two. Just some people have to log on. I'll just give one more minute. We've got about 12 people now. Okay, 13. All right, I think that should be good enough to start because we do have a couple of minutes of intro. So for the people who are coming in afterwards, they should be able to pick up on where we are. So welcome. Bienvenue, Pijashig, to the January edition of the Public Health Virtual Journal Club. I'm Danielle Tremblay. I'm CPHA's Communications Manager, and I will be your host today. I would like to start off by acknowledging that we're all coming to this webinar from different parts of Turtle Island. CPHA's office and my home are located on the unceded territory of the Algonquin Anishinaabe Nation. CPHA is committed to meaningful truth and reconciliation with all First Nations, Métis, and Inuit peoples, and to that end has established an Indigenous Advisory Council to guide its path towards reconciliation. A few housekeeping notes before we begin. If you would like to ask a question, please do so by using the Q&A module and not the chat feature if possible. We are recording today's webinar and it'll be available on our CPHA YouTube channel. All you participants will receive an email containing a link to the recording once it's available. And it's now my pleasure to introduce Monica Imode, the student member of CPHA's Board of Directors, who will moderate today's session. Over to you, Monica.
Thank you, Danielle, and thanks everyone for being here today. I'm super excited to welcome you to our first Journal Club session of 2020-21. And it's my pleasure to welcome you to this Journal Club series that's held in partnership with the Canadian Journal of Public Health. So at CPHA, one key area of our work is to advocate for public health, speaking up for people and populations to all levels of government. And we champion health equity, social justice, and evidence-informed decision-making. We're a catalyst for change that improves health and well-being for all. And our vision is a healthy and just world. And our mission is to enhance the health of people in Canada and to contribute to a healthier and more equitable world. And you can follow on the conversation during the Journal Club with CPHA's Twitter handle, which is here in your screen, on the screen. And the Canadian Journal of Public Health is an independent journal that publishes peer-reviewed original research and scholarly articles submitted in either English or French that are relevant to population and public health. This journal aims to advance public health research and practice in Canada and around the world, contributing to the improvement of health and populations and the reduction of health inequalities. And you can also follow along on the tags, the Canadian Journal of Public Health by their handle that's also included here on Twitter. So for the past 4 years, we have been holding a webinar series to engage our members. Initially, this series was intended for our students, trainees, and early career professionals with the goal of promoting public health careers. You can find the recordings from these past webinars on our YouTube channel. And so this year, we're holding a series in partnership with the peer-reviewed journal that we publish, the Canadian Journal of Public Health. And each month, a graduate student will critically appraise different journal article and will engage in the paper's author and discussion. A committee of devoted volunteers have identified the first 4 papers, and we'll identify the next as in actually all 8 papers. And so registration for the webinar is open a month prior to them taking place. And so our hope is that these journal club sessions will continue to provide a supporting learning environment for the participants to keep abreast of the current public health literature. You'll get a chance to develop some skills and competencies in critical appraisal, and we can expose attendees to a range of methodological and analytical approaches used in public health research. We hope you'll find these sessions to be invaluable throughout the year. And you can follow along our conversation using the hashtag CJPH_J Club. I'm looking very forward to another exciting webinar presentation and a thoughtful discussion. But before we begin, just a little bit of housekeeping. So as Danielle mentioned, all participants are muted, but we hope to engage you through the webinar through other polls and other features. And the toolbar at the bottom of your screen has a few features. So if you have any general comments, please feel free to post them in the chat, and these will be visible to everyone. We also encourage you to chat. We encourage you to chat amongst yourselves. We encourage you to chat amongst yourselves through in the chat box. And we can also continue the conversation on Twitter. And if you have any questions for the presenters, please feel free to post these in the Q&A box, which will be visible to all presenters, and your questions will be answered in sequence. And this webinar, just a reminder, this webinar is being recorded, and that this recording will be available to our members within the coming weeks. And slides and recordings will be shared more broadly with the public in the next 3 months. And so now we get to learn more about who you are. And so I'm going to share a few polls on our screen. So it seems like the primary interest for today's discussion is around policy and practice and knowledge translation. But of course, since it's journal club, we're also trying to sneak a little bit of methods in there for those of you who may be interested. And I'm also curious to know where you guys are coming from today. Right. So of course, lots of people are from Ontario, and as well as the Atlantic today. Thank you, Danielle and Tong. And for our final question, I'm curious to know what your area of focus is of the attendees. Great, so lots of people today here in research. And so without further ado, I'm really excited to introduce today's speakers. So today we have our presenter, Muna Farah. Muna is a medical graduate from Capital Medical University in China. She has spent the last 10 years working in community outreach, both with grassroots organizations and international humanitarian organizations locally and abroad. Muna is currently the Health Promotions Activities Manager for Doctors Without Borders Canada. Our author, Tong Lu, she is a senior research associate in the Department of Human Health and Epidemiology at Dalhousie University. Her current research covers social epidemiology and public health policy in Canada, and her focus is on working with large data sets, handling complicated statistical problems, and providing a timely analysis on the real world health and policy problems. And she graduated from the University of New Brunswick with a master's degree in economics. Her primary interests include health economics and applied econometrics. And our senior author, Dr. Daniel Dutton, who is an assistant professor in community health and epidemiology at Dalhousie University. Most of his work is quantitative, utilizing large data sets and modeling strategies from economics and epidemiology. His primary interests are population level exposures and their impact on poverty and health, how governments can address those exposures, and the distributional impacts of addressing these exposures. So currently that work focuses on homelessness, low income, and governmental policy. And without further ado, I'll pass this along to Muna so she can begin her presentation.
Thank you for that introduction, Monica. I will be sharing my screen. Thank you for all joining us today. As Monica mentioned, the paper I'm presenting is by Dr. Dutton and Tong, and it's called "With Great Inequality Comes Great Responsibility: The Role of Government Spending on Population Health in the Presence of Income Distributions." So I'm going to start by talking about the background information that the authors went into, why they went into it, and the methods that they did to come to these conclusions and their results. And then we'll open it up to a Q&A discussion. So I'll be speaking for about 10 to 15 minutes, and the rest of the time, we will just be having a Q&A discussion. So without further ado, the objective of this study was to measure the role of government health spending and the role of government health spending and social spending, and how that has an impact on the overall population health. And the authors, they stratified it by gender. So they compared men and women. They collected data from 9 Canadian provinces between the years of 1981 to 2017, over a span of 37 years. And the sources that they used were Statistics Canada to reference for health outcomes and demographic data. They also used the University of Calgary School of Public Health Policies to account for the provincial spending data. They then associated these ratios with the Gini coefficient to allow for income inequality modifications. So before we get into any further discussion about the methodologies, it's important to discuss why they decided to go down this road. There is an assumption that spending on healthcare is more worthwhile to the overall population of health. And that's not always the scenario. There's an overwhelming body saying that the social determinants of health plays a role into the overall populational health. And then the authors, they decided to go down this route of separating it by dependent variables of health outcomes and independent variables of health outcomes. So what those dependent variables of health outcomes were the potentially avoidable mortality, life expectancy, the potential years of loss of life. So they stratified it by, these were the dependent variables. And the independent variables were the Gini coefficient and the percentage of population over 65 years, the unemployment rate. Those were independent of the overall population health. They then continued so before I continue, they used Gini coefficient. So what is the Gini coefficient? Why is that necessary? The Gini coefficient is a tool to measure income inequality over populations. And it's a scale that's measured between 0 to over 1. And to kind of give you an idea, 0 is here. And as you increase the population over time, the line of equality should increase, ideally, but that is not always the case. So with variable levels of incomes, there's going to be some changes. And this area is a Gini coefficient. So what the authors found is that social spending in Canada is almost always lower than health spending. And per every health outcome, men have less desirable means than women. And they have a higher potentially avoidable mortality than women at a rate of 387 versus 208 per 100,000 people. They also found that these were the numbers overall, the potential years of loss of life were 6,331 to 3,401. And lower life expectancy and infant mortalities are all the numbers between men and women. And almost always men were higher than the women. There's more data on how they found between how the government was spending on money, so the spending on health capita and what the Gini coefficient were after income tax, post-income tax, and how that played a role into the overall health outcomes. What they also found was that the real health spending over Canada, so this line here is how the government was spending on health, and the social spending remained relatively stagnant over the last 37 years, while health outcome was steadily increasing. And then they compared that with social to health spending ratio, and they saw the ratio overall was going down. They found that after 2003, the Gini coefficients for the provinces shifted from their previously common trend, leading to what they called an S-line, what is called an S-line shaped model. And what this shows is that from 1981 to 1987, there was a decline. And at 1987 to the early 90s, you saw a steadily increase. And it's still increasing, but then we're starting to go back down. There's a number of reasons why, and a large portion of that is due to the fact that social spending has been changed. The way that the government has been spending on social spending has been stagnant, as we previously mentioned, whereas they've been increasing more on healthcare spending. And over here, they mentioned that the social to health ratio is at a linear decline, or linear increase, actually. So the ratio, they found that the ratio is relevant to changes, was not relevant to changes in their non-infant, it was more relevant to the ratio was more relevant to the non-infant population. So it didn't really have an effect on the infants, but the population health outcomes were better in provinces where they have higher levels of ratio. And the mortality outcomes improved in the presence of higher than average income inequalities. They also found that men on average exhibited a stronger association between health and the ratio in the face of increasing income inequality. The ratio has decreased over time in most provinces, and that was driven by a steady increase in health spending. The results suggest that as income inequality increases, the provincial governments should direct resources to more social spending. And so these are more data that they found. They used the linear regression. So they used a linear regression model that they built, and they stratified it by genders, and they used these variables that we previously mentioned, which are the potentially avoidable mortality, lower expectancy of life, potential years of loss of life, infant mortality, low birth weight, and then they stratified it again by using the independent variables, and these were their results. And this is specifically for men, and they did the same thing for women. And furthermore, these are, again, when they broke it down even more to potential years of loss of life versus men versus women and potentially avoidable mortality, men were almost always higher than women. The conclusion is that the study indicates, the conclusion was that there were similarities in how the spending was overall for men and women, but at the end of the day, there was a higher impact on men. And there are societal implications for that. The authors found that sometimes men were the recipients of more, they relied heavily more on social services like homeless shelters, so on and so forth. And then the impact of the overall inequality is felt more by those who rely on those services. In this case, they found that men relied on it a bit more. And the study suggested that the first step, the overall conclusion was that the study said that the first step in reducing this income inequality would be to try to reduce it to the levels that it was in the early 1990s, at a time where social spending was more in alignment with health spending. So I'm going to stop there and ask questions to the authors.
And I'm just going to jump in here and say that if you do have any questions that have come about the presentation that you want to ask, to feel free to ask them either in the chat or the Q&A session, so we can start answering those as they come up.
Yep. So I'll start with my questions, and they are, so I'll start off by first off saying that was a very interesting paper to read, to compare just reading on how you found the data over the last 37 years and how things changed in Canada. In the end, you concluded, I'll start off with the conclusion, and you said that there's marginal changes in social spending, and that would be the first step to changing it back to the levels that it was in the 1990s. And that can benefit the population overall. So I guess my question is, as Canada's population changed over the last 37 years, how do you suggest we go about that?
Thanks, Mara. First of all, thanks for the presentation. It's always tricky to present when the person whose paper you're presenting is sitting there watching you present. So I think you did a fine job going through the material. So this statement you point out is about how we've made small changes over the past 40 years or so away from spending on social services relative to health spending. It's sort of an insidious process. We kind of decide what to do with our marginal dollar as a society, or those politicians set objectives and then we don't want to do that. And so we're talking about how those marginal dollars could produce a larger population health benefit if we put them into social services. And now the makeup of the Canadian population, of course, is relevant to the consumption of social programs and health programs, which is why this relationship being kind of robust over time is so enlightening. It's not that we see, this relationship holds for recent time periods, but not others. Tong could speak to this more than I could, but we went through a number of different modeling exercises where we would cut our data into chunks and look at different time periods. You showed the S shape of the relationship between health and social spending and the Gini coefficient over time. If that's, I hope to God that's what it is. Excuse me, got it right here. The Gini coefficient over time, sorry. And so we thought, okay, well, what happens if we cut it into pieces? We have low Gini coefficient time periods and high Gini coefficient time periods. And the relationship seems to be the same. The Gini coefficient kind of changes the impact of the marginal dollar, but we see this story remains the same. So I don't think that the government, your question is sort of like, should the government respond differently? I think that the programs that people consume will likely change. But undoubtedly, like, the enrichment of those programs improves the environments within which people are living their lives. And I think that's the main takeaway story. Tom, do you have anything you'd like to add?
I think your answer is good. I agree.
Very, very diplomatic. Thank you.
Thank you for that. I guess I'm curious to take a little bit of a step back and be like, and ask what happened as you were doing this research in this paper? Like, what did you find? Yeah.
Oh, okay. Yeah, okay. I can give you guys a bit of the history. So back when I was a postdoc, I worked at the University of Calgary, and a couple of researchers there, PG4A, Jennifer Spricker, and Ron Kneebone, were kind of kicking around the idea of talking about the international evidence on the what's called substitutability between health and social spending with respect to population health income outcomes. And it had been shown for the States. And when we think about the States versus Canada, we like to kind of hold them up as an international healthcare comparison because we spend less on our healthcare system and we have better healthcare outcomes. We attribute it to the public funding of the healthcare system, decreasing the variability of outcomes amongst those who are the lowest income. Like the access problem in the States is a significant problem. But then in Europe, we were seeing similar results where social spending seemed to have a higher return to the population health spending. And we definitely don't think of European countries as being similar to the States in the same way we think Canada and the States are very different. And so we wondered if this existed for Canada. And so somebody at the University of Calgary, Ron Kneebone at the University of Calgary, School of Public Policy and Department of Economics, just so happened to be compiling this government spending data. And it was sort of a natural opportunity to take advantage of his interest in doing this thing that like nobody really else seemed to be interested in doing, compiling this government spending data and running that against publicly available data of health outcomes. And so that was the very beginning of the project. That was published in the Canadian Medical Association Journal. And then I got a job at Dalhousie. I met Tong, and we were talking about, well, what else can be done in this social and health spending environment? And the inequality question and the sex question came up, and we thought, okay, well, let's stratify for males and females, because we had this idea that perhaps specific sexes might have different results by these public population health outcomes. And it wasn't. I mean, we found a difference, but the difference wasn't drastic by any means. And then we explored the inequality problem, and that was, an interesting kind of pattern over time and seemed to be related to the health and social spending ratio. And so we kind of it just grew organically from what we'd already done. And there had been growth in the data since that first publication. And so it's nice to check to see if things still hold. So one of the things you don't observe is Tong put a lot of work into figuring out if the past paper's results held with the new data set. And so I was sitting there waiting to have a heart attack when I found out that the results had totally changed. But thankfully they didn't. And so Tong saved my life there. And then we just went from there. Tong, anything you'd like to add? Am I remembering this differently? Maybe I have rose-colored glasses and it was actually a terrible time.
Yeah. So this research is basically an update of the previous research done by Dan and Dr. Nibon. So because we have newer data now, so we would like to update the time period with newer data and also make a update research with the income inequality questions and the gender specific questions. So yeah, that's basically what this research started.
I appreciate that. It sounds like, Daniel, the stars kind of aligned for you just doing this research.
I have to say that it is kind of like making Japan out of a nice situation, because it was, I don't think there is a nice set of data on government spending in Canada. I think what Ron Nebon has put together is very usable, but across provinces, the way that provinces report spending on quote unquote health and quote unquote social spending is different. And so, and also governments change the way that they report over time based on seemingly random accounting decisions, how they would like to account for future spending, whether they allocate it to the current year or not. And so all of these changes happening over time, which they will then retroactively change their other public reporting numbers, add kind of noise to this problem. And I think that that would be, in my mind, a natural place for growth. So if governments kind of come up with a standardized cross-Canada way of presenting their budgets, that would allow for additional people to take advantage of this kind of data. And already huge amount of publicly reported population outcomes data that we have in Canada. So we have a lot of information on health outcomes, and then kind of a few messy ways to track what governments are spending money.
Just to confirm before you go forward, Muna, is that data publicly available, the Calgary data set, health spending?
Yes. It's on. So it's not the easiest thing in the world to find. It's definitely linked in the paper. There's a hyperlink. It's on the School of Public Policy's website, and I'm just going to go ahead and assert that Dr. Nebon would love to get emails relating to his data set. I'm just going to go ahead and say that. He would probably love for me to be advertising that he's open to receiving emails at all hours of the day on any topic, but particularly this data set.
Okay, thank you.
Before I go into my next question, I do want to say thank you, Tong, for putting all that data together. I know it could not have been easy, and we're just reaping from the benefits of your labor, so thank you.
You're welcome. This is the interesting part. Like, this is the research.
Yeah. So my next question is, why did you choose these methods?
I would say the first important reason is that we were using longitudinal data. So I'm from the economic department. I graduated from an economic department. So fixed effects model is a commonly used model for estimating causal effects from panel data. So it is very suitable for our situation. And also like, it can observe changes over time. So that's why we choose to use the fixed effects model.
Yeah, this kind of underlines one of the challenges in an interdisciplinary field like health research at large, is that people have like different pieces of jargon to describe the same thing. And so I think in some disciplines, what Tom and I call a fixed effects model is sometimes called a random effects model, which means something completely different within economics. And so finding a methodological common ground is easier if you sort of stick to these fundamentals. So this, what we're calling a fixed effects model here, is essentially the like nothing fancy version of longitudinal panel data analysis. And fancification increases as much as you'd like it to as you move forward with other types of models. But really this is, it controls for time, and it controls for a unit specific effect in the province. So the province is the observation. We also have fixed effects for time, and that's what we mean by two-way fixed effects. Other places, other people, researchers use the term fixed effects to mean the stuff in the model. So the independent variables they refer to as a fixed effect, and then they refer to those things I just described as random effects sometimes. So it gets very confusing. If there are trainees present, I guess my recommendation would be able to speak to what your model is doing rather than throwing around the jargon, because last thing we want to do is get into a unclear jargon-based knife fight in public with someone during a seminar. So that we did this. It's a very common tool in labor economics. It's commonly used.
Thank you for that explanation, because folks like myself don't have an economics background, so it's interesting to see how the model's used.
You know what, you've seen it before. It's a regression where it's analogous to having a dummy variable for each observation. So it is not doing that, but it will mechanically get you the same result as a regression when you have a dummy for each province, essentially.
Yeah, thank you. And why did you choose to publish on the Canadian Journal of Public Health?
Oh yeah, sure. I can answer this. So the previous article went to the Canadian Medical Association Journal. The Canadian Medical Association Journal is highly read. The audience is a lot of physicians, but also the media pickup is quite good, and I think it was a great place to place that paper. But we wanted to describe this a little bit more, and the CJPH has a higher word count, so that's very nice. But also the readership of the CJPH would be more people who are interested in like the policy applicability and also like inherently interested in this problem of inequality, which we found to be like the underlying theme of this paper, the motif for our take on the data. And so I think that getting this out in the CJPH is important because, well, I don't think it's like, I mean, it's Canada specific, it's Canadian data. I think it has sort of some applicability outside of Canada, in the idea that social spending's return is probably higher in an environment where there's higher inequality. Like I don't think that that's a Canada specific thing. But it is important because this is Canadian data on Canadian health outcomes that is potentially picked up by Canadian policymakers in this country. So that's why I think CJPH.
Yeah.
There are lots of considerations, right, when you're trying to get something out into a journal, I guess. And some people are more strategic. I have to say, like, I kind of aim for like the readership, like I sort of something that I picked up from people who I looked up to as mentors, is they sort of talk about the importance of getting your research read. And I thought, yes, that's a good thing. Of course, as a guy trying to get tenure at a university, I'd love to publish in like the highest impact factor journals in the world, but that's sort of inappropriate in this case. I think that getting practitioners and public health professionals to read this work is probably a good priority.
Absolutely, absolutely. And I guess, do you have any recommendations for improving the collection of health or provincial spending data used in this analysis?
Yeah, well, I already said that thing about how provinces report their information differently. Let me give you an example. So Tong and I are both based in New Brunswick. Dalhousie has a medical school here, and we're both there. And in New Brunswick, what we would call in most provinces in Canada long-term care, so like institution-based care for people who are no longer able to live by themselves at home, is called social spending. That's in the social spending envelope, but in most other provinces, it's in the healthcare spending envelope. And so like seemingly random decisions like that make it a bit hard to compare across provinces. So the spending comparability across provinces is definitely the biggest challenge. So like Prince Edward Island, for example, Prince Edward Island is not in this study, not because I have anything personally against Prince Edward Island. It's just that Prince Edward Island reported health and social spending as one column in their budgets in like the 1980s and 90s. And so they don't look the same. They gotta go because I want 37 years of data. I guess we could shorten the number of years of data and include Prince Edward Island, but it doesn't have the same variability in Gini coefficient if I don't have the long time period. So you got to make these decisions when you're working with them.
If I can jump
yeah, go ahead.
If I can jump in, so I'm really curious to know. So you mentioned that you have all these different types, all these years of data, and I'm curious to know if you ran into, for the provinces that you did include, if you ran into any issues with missing data that might have occurred over the time period for certain provinces that you did include around any of the outcomes, perhaps.
Tong?
So, so your question is, like, can we?
So I'll just repeat. I don't know if you can hear me. I said, so I'm curious to know, because you had to collect the data over a long period of time. So for those 9 provinces that you did include, I'm curious to know if you ran into any issues with missing data and what you did to kind of accommodate to deal with that.
The insufficient data. So
yeah, so
missing data. So a good example, Tom, might be the cancer data, if you want to talk about that.
Cancer data. So yeah, we did think about adding those cancer incidence or some other chronic diseases data in our models, but and we tried that, but the results are not very significant. And also we do have a lot of different options for the health outcomes. So we decide to limit those health outcome, the number of health outcome variables. So we feel like use some more intuitive and straightforward outcome variables are more understandable. Yeah, so.
Oh, thank you.
Yeah.
So I think,
sorry, I'll just add one more thing, Monica, there. So in terms of spending data, nothing is missing because the government has to put out these public, they're called I'm forgetting it, public accounts, essentially. It's like, so the budget is, here's what we promised to spend money on, you gotta believe us. And then the public accounts is, here's what we spent money on last year, broken down by their line items. So they have to put that out legally. And so thanks to the heroic efforts of people who are interested in assembling public spending numbers, there's no missingness there. Now, I'm certain there's judgment calls that had to be made, and that's why I advocate for standardized reporting of spending. But with respect to the health outcomes, so cancer registries, for example, exist in some provinces and not others, and do a better job of gathering cancer incidents in some provinces and not others. And it doesn't go back as far as variables like life expectancy, which has been gathered forever. And so we had to make a call, so the cancer incidence thing, I thought it'd be really interesting to look at cancer incidence by this social health spending. Feel free to steal that idea, everybody on the internet, now that I've said it here. But I just couldn't fit that story into this data set because it didn't exist for the amount of time that we had data for. We already had results that we could speak to. So I think that the key to this type of work is a lot of so we are definitely not inventing this. This is part of a larger literature that exists already with Canada and other countries, and nobody else has. It's not like you've never heard of the social determinants of health before. We're just talking about it from the government expenditure side. And so we need additional people working in this space to build a compelling case to get over this problem of there's some missing data over here, there's some data over there. With a higher volume of work being completed, I think we'll be able to triangulate the true issues.
And I think that raises such a really important question around priority setting, and not just in the way of research, but also in terms of how governments think about budgeting. And so in public health, we often talk a lot about social programming or social spending and how that can be used, as you mentioned, to kind of enhance the life of equity-seeking populations. And so if I had to think about putting my economics hat on, and I recognize that there are, as you mentioned, there's a finite number of resources available and you have to commit to spending a certain amount of money. And so this is a tough question. And so I don't envy those people who have to make those decisions about where the money should be spent. But I'm really curious around, so we're talking about knowledge translation and communicating these findings to policymakers. And I know you guys advocate for a marginalized increase in social spending. I guess based on your experience in the economics field and thinking about government and how they spend their money, and because there likely is a finite number of resources available, where do you think that extra social spending or that increase in social spending can be leveraged from, or where would you recommend, just based on your field in the area? I know those are tough questions. I'm really curious to hear yours and Tong's thoughts on this.
So yeah,
I'll go first.
Like increased social spending itself can kind of reduce the income inequality problems, because like social spending is aimed to help those low income groups or people who are unemployed or disabled. So adding the social expenditures can kind of solve the income inequality problems, and also from our results, if you increase the social spending, which means increasing the ratio, it has positive effect on people, on the population health. So our suggesting our study is that if government increase the social spending, so it can not only improve people's health outcomes, but also like reduce income inequality problems. So that's why that is.
So just to clarify, I just wanted to know. So if the goal is to increase social spending to benefit the populations, I guess my question is around where do you think that money can be leveraged from in terms of a government policy position if you had to make decisions about where your budget should be? And I know that's more of a policy oriented. I'm just curious to know what your thoughts are on that.
Yeah, so one of the things that we did in this paper and in the previous paper was we put in a term for total government budget, meaning the way we conceptualize this ratio is of decisions made within the current envelope. So money, the implicit assumption in there is that you could take money from the healthcare system and put it into the social serving system and come up with what the result we're talking about. I think in the previous paper we do a little back of the envelope calculation about like the redistribution from health to social spending is something like less than 1% of health spending, but a substantial increase in the proportion of spending for social service, something like 3%. And so, you know, we're not talking about cutting per se, like health and social budgets grow year over year in nominal terms. And so if you slow the growth of health spending and put it into social spending, you get a better population health outcome according to our papers. And I'm using causal language because we're having this discussion, obviously caveats apply. But the rhetoric around healthcare spending is that healthcare spending equals people not dying. Like I was at a hospital around here, and I got swept up into a protest because that day the government had said we are going to close the emergency room of this one hospital in a rural area. So there I am, minding my own business, and probably 300 people came into the emergency room waving signs, seniors deserve the emergency room, because they saw this question as, do you want an emergency room or not? But in reality, we as like Canadians, the question is not, hey, do you want an emergency room or not? Nobody's gonna say, no, I don't want an emergency room. But the question should be, do you want an emergency room, or do you want greater care for these people who are high users of social services? And by the way, if we do not provide this care, they will go seeking the care they need in inappropriate, perhaps more expensive settings, such as emergency rooms, right? So it's sort of like thinking about the problem that we're trying to solve holistically instead of in silos, which is what it's just how governments rhetorically frame their problems.
No, it's true. And I think you're right. That speaks to that tension of priority setting of having to make those difficult decisions that are life decisions. And I'm curious to also know if, in a question from the audience, are there any specific areas of social spending that you would find that would benefit the most?
Yeah, I see that. So we're talking about the question from Brandon. Yeah, so I recently wrote a thing for the government of New Brunswick on deep poverty. Okay, deep poverty is the idea that people who are 50% below the poverty. So there's people who are below the poverty line by like, tiny amounts, and then there's people who are way below the poverty line. Those people, the people in deep poverty, are almost all living on social assistance. So in my opinion, the one policy change that would make the biggest difference for a lot of people living in low income settings, and which looks like social spending, according to our study, is increased social assistance payments. Those things are not, in a lot of provinces, not indexed to inflation. And so in real terms, people are just poor and getting poorer, where we could just legislate that change and by construction, decrease deep poverty.
And And so
I'm also taking it for granted that everybody's fine with the income is correlated with health. But let's not go there.
So yes, and I think in your paper you also mentioned that as well, so that there's a stronger association between the health and racial spending. And so I'm curious to know if you think that, and you talk about the gender difference and the importance of that. Do you think there are any, especially any gender-centric solutions that we could have in terms of increasing social assistance payments that we could use, or to kind of address that gender-based differences in social spending, health and ratio, between the ratio of the health and social spending?
I think one of the surprising things there was that we saw, if there was a difference, the difference was slightly like favoring males in the sense that males would benefit from it slightly more than females. But I think that females also have like just better outcomes with respect to all of our health, like longevity outcomes. They just live longer, have fewer years of years of life lost, and potentially avoidable mortality. And there's definitely like a social element to this. It could have to do with the environments within which people work, etc. But I don't know. So like when we think about sex-based differences in living environments, for example, we think about if a parent is raising a child by themselves, that parent is normally the mom. That's just more likely. But we didn't really find like anything that I can point to and be like, haha, bang, here's your gender-based lever upon which our outcome rests. I don't know, Tom, do you have any insight into that gender issue?
Yeah, so like we said in the paper, like the majority of people who are experiencing homeless are men. So, and also men are more sensitive to the effect of the social to health spending ratio at the higher income inequality level. So we would say like address those issues by some kind of social assistance payments might be important. And also, for example, like maybe increase the social assistance on the shelter use, that might be help. And also I think like increasing social spending itself can do solve this problem at some level, because men are more sensitive to this problem. So if you increase it, that would, like, men are also benefit more from this policy.
Yeah, simply the enrichment of currently existing social programs is kind of like a nice message, because we're already doing these things. But like, I don't know, name a social program that says it's perfectly funded and doing fine. I do see. Oh, go ahead.
I was gonna say another question from the audience, but I'll read it out for those who can't see it so you can answer. So someone asked, on the note of deep poverty, do you see a possibility of economic development being used as a social spending, or rather, is it worth it? And another question to go with that. So also, did you see any possible underlying trends as to why there is a gender difference in social disparity?
Oh, geez. Like, I mean, all these things are related, right? So we are using this government spending data to look at something that has been shown in a number of other different environments. And so we see that, like Tong mentioned, homelessness is in emergency shelters, we mostly see males. And some people suggest that it's because, females who are in similar situations actually can rely on their networks better. There's all sorts of reasons why we expect that exists. But from our perspective, we're saying, we're already talking about downstream stuff here. We're already talking about, like, you can either go to the healthcare system, or we can use our social care, quote unquote, social care system to mitigate the damage that this poor hand of the social determinants of health is doing to people. That, in my opinion, needs to happen in tandem with processes that are fixing these upstream processes that are generating people relying on these programs. That is not just like a change in government portfolio arrangement. It's something that we need a sort of full court press from all people. I think there's lots of researchers working towards that. So I wish I could say that we had identified something key that is absolutely a priority. But reality, this is just looking at the large portfolio aspects. I do see another question in there. I was just going to jump to it, but maybe Monica, you should moderate it instead of me just going wild.
So the next question is, why do you think infant-related outcomes do not have statistically significant association with the ratio? Any thoughts on that?
infant mortality is highly related to the healthcare system. And I think in other jurisdictions like the States where we see infant mortality matters with that social health spending ratio, it's because access to the healthcare system is not uniform there. So the same people who benefit from social spending are the same people who actually don't have high access to the healthcare system. And I think that in Canada, it's been shown, not just our work, but other people's work, that the infant mortality rate responds to sort of our blanket healthcare coverage. We're really good at keeping you alive when you're like less than 1 year old, but then you're on your own. And if you need better social care services, I guess we'll see you when you show up in the healthcare system. Like I think that is how it has been interpreted. I did see there was another comment I missed on the last one about economic development. I wonder if that means the current health and social ratio is related to business cycles, sort of like people have service industry jobs, stuff like that. I don't know like if this can be tied to an income issue. Like we treat the income distribution as given and the government is facing an income distribution. Certainly there's some like room for legislation of labor markets, but I don't really have a good answer for that. So, Tong, anything to add to this infant related outcomes issue?
Yeah, so like technically, like in a statistical analysis, sometimes the insignificance of a variable can be because of a lot of different reasons. Maybe we like there are a lot of confiners might affect the results, and also like and also that happens a lot in research. So sometimes you expect to have maybe like a negative relationship between them, but the insignificant results do happens a lot. So the reason it's complicated is some control variables, the effects of control variables can also like influence it. So yeah, so it happens in research.
I just want to pause here and ask Muna if she has any additional questions she wants to ask.
I did see a question as I was putting this together, and it said that aside from the dependent variables that your study considered, would you consider studying intermediate health endpoints like food security, prevalence? And I know those are all in the social area. So to round it up, so food security, prevalence, incidence of non-communicable diseases, would you consider anything?
Yeah. I think that's interesting because you do have, things like food insecurity highly related to health outcomes and driven by income. And so we can imagine if there were a program that improved the income of the lowest earning people, that would probably have an impact on food insecurity. We've seen it with guaranteed annual income for people when they switch onto a publicly funded pension, that their food insecurity drops. And so I think that is, there's definitely room for that kind of analysis. I think that the incidence of chronic diseases is definitely 100% something that is amenable to this type of analysis. Diabetes, for example, or cancers, or
heart disease,
hypertension, heart disease, all of these big ones, I imagine follow a similar pattern. And I think it's because underlying all of this is the social gradient in health that we're all very familiar with. Yeah, I think there's definitely, and that's part of what Tong was talking about with the missing data problem, that we pulled down a bunch of Statistics Canada data on these things. And yeah, if anybody wants to collaborate, let me know, because we got results, man. So we just need somebody to make sense of it all. But I got so many emails.
That's very interesting, because I do remember, to build off on that a little bit, I do remember there was a point in the paper that you'd mentioned, and I think it was from a previous study, that the elder population benefit more from social spending, and to average it out, for anybody under the age of 45, they'd have to get an additional $947 per person. So I'd like for you to explain a little bit more, if you can.
So that's not my work. That's from somebody named Paul Kershaw at the University of British Columbia. And he did, oh geez, let me get this right. So he looked at spending that benefited people above age 65 or below age 45. Tong, you remember this?
Mm-hmm. Yeah, the Canadian pension income.
Sorry, I saw you nodding. I thought you knew what I was referencing. It's more like they took government spending and allocated it to people above age 65, people below age 45. And yeah, they said that for it to be equalized, people below age 45 would need to receive an additional about $950, something like that, in services. And then Dr. Kershaw makes the argument that something like free childcare or highly subsidized childcare is like lower than that amount. So we're basically saying that if you consume some types of government spending, that's fine because you're age 65 or over, and we just have some notion of that being okay. But if you're below and you're a child, no, we don't really think that that's appropriate. So he underlines the fact that this is all just socially determined what we feel like we can spend money on, rather than some sort of, law about what kind of spending is allowed. And he shows that over time that balance has shifted, but it's always been sort of pro age 65 plus. And when people live longer, of course it's going to look like we're spending more on that age group. And that mostly comes through health spending and health sucking up an increasing amount of government budgets, healthcare systems, that is.
I found that to be a very interesting correlation with your paper overall, especially given that like men were on the lower end of the scale when it came to receiving social services. So I just found that to be a very interesting correlation to connect. So
I think, thank you. I think that when we look at these questions in these big chunks, people over 65, men and women, we're just trying to take different approaches to the problem of the environment within which people live their lives matters. And if we can group people into groups that already look like groups we think about when we're solving problems with government spending, then it becomes an easy conversation to have with policymakers, right? So if you walk up to policymakers and you're like, hey, it's a really good, important priority. This people experiencing homelessness, we need more funding for emergency shelters, we need more funding for housing programs like Housing First. A policymaker can very easily say, thank you very much, Dr. Dutton, that's important. But it's also important, I need to build a school in this area where there's no schools, and this highway is broken, so I need to fix that highway. They have a number of competing costs at any one time. So being able to put it sort of like as a business case, some people cringe and they don't like the notion that we're talking about value for spending, but it's one way to operationalize the problem that people are already looking towards. I see Dale's pop up.
And I think that's a perfect way to end our discussion session.
Oh!
We have a few minutes remaining. And thank you. So on behalf of CPHA and the Canadian Journal of Public Health, I want to thank both the authors and Muna for your fantastic presentation and wonderful discussion today. It's been so great. And I hope that we will continue this conversation on Twitter. We encourage you to use the hashtag CJPH, CJ_J Club to continue the conversation. If you have any additional questions that we didn't have opportunity to answer today. And I just wanted to promote our next Journal Club session, which will take place on Wednesday, February 24th. And we will be discussing a paper, Changes in Health Behaviors During Early COVID-19 and Social Demographic Disparities, a cross-sectional analysis. And as always, you will be able to register online. I believe that's, and CPHA members can register for free when logged into the CPHA membership portal, and non-members should register for the webinar series on the CPHA website. I believe that is posted now. And the last but not least, if you are not currently a CPHA member, we encourage you to consider joining. So membership is a great way to connect with Canadian public health professionals, such as our authors here today. And there are many benefits to joining, including student opportunities like free access to our webinars, eligibility to participate in a mentorship program, and other leadership roles. So if you're interested in becoming a member and learning about current student and early career opportunities, I'd be more than happy to have a one-on-one conversation with you. So please feel free to reach out to me by email at students@cpha.ca. And thank you again for taking time out of your afternoon to attend today. And thank you again to our presenters. for a fantastic presentation.
My pleasure. It's very humbling to be invited, and I was very happy to see how many participants were here. It fills my heart. Thank you.
Yeah, thank you very much for interest in our paper.
That's great. Thanks very much, everybody. Have a great rest of your day, and we'll hope to see you next month at the next webinar.
Thank you. Bye.
Thank you.
Thank you, Muna.
Thanks.
Thanks, Tong. Thanks, Daniel.
Great, thanks, guys.
That was great, really.
Okay.